Hello all, welcome to Physio TV. Today we have Dr. Dorcas Gandhi, who will be talking on post-stroke upper extremity rehab. We have our moderator, Dr. Prema Khatri ma'am.
Hello.
Prema ma'am has been a professor and HOD at RNPC, Wardha, and she was later a professor at Nanded Physiotherapy College and Research Center, Nanded. She has had various administrative positions, and she was also one of the chairperson of Board of Studies in Faculty of Paramedical Sciences. Ma'am has 36 years of clinical experience, and currently she's having a clinical practice at Chandrapur. She has 15 years of undergraduate teaching experience, 9 years of postgraduate teaching experience. After you, Prema ma'am.
Hello. A very good evening to all of you. Today, I'm so honored to welcome Dr. Dorcas Gandhi. I am honored to share this platform as a moderator for today's session. I take this opportunity to welcome Dr. Dorcas Gandhi. Hello and a very good evening to you, ma'am. Going ahead with a brief introduction of Dr. Dorcas Gandhi. She'll be speaking to us today on upper limb rehab and stroke, mainly the motor aspects and the current evidence and continuum of care. Her current affiliations are as follows. She is an associate professor, College of Physiotherapy, a clinical supervisor, a tele-rehab consultant, a research fellow in the Department of Neurology in CMC Hospital, Ludhiana, India. She is a recipient of DBT India Alliance Wellcome Trust Research Grant 2018. She is also a recipient of World Heart Federation Seed Grant 2019. She has developed and implemented training modules on stroke rehab in Bhutan, Maldives, and Timor-Leste in collaboration with WHO. She is also a Lancet Commission Fellow 2021. She has publications, over 20 publications in peer-reviewed and indexed journals, with citations more than 300, with an H index of 8, an I index of 6, and RG score of 24.17. She has received many awards, a few of which are Young Fellowship Award, Indian Federation of Neurorehabilitation 2021, Travel Grant for Young Investigators ESO 2019, Young Investigator Award by World Stroke Congress 2018. She has also received Emerging Leader by World Heart Federation 2018, and she also has, among others, Top 10 Abstracts in Recovery and Rehab Travel Award, ISC 2016. So here I am to welcome Dr. Dorcas Gandhi. Over to you, ma'am. We are eager to listen to you.
Thank you so much, ma'am. I'm really humbled to be introduced by you. I certainly have heard a lot about you from my other peers and colleagues. So it's really wonderful to have you with me. And of course, feel free to pitch in anytime if I'm missing out anything in the lecture. So the topic for today, like Dr. Khatri mentioned, is post-stroke rehabilitation, especially for the upper limb. And to keep it short, I will be focusing on the motor aspects for today. So this will just be an overview. I would be focusing, there are many approaches that are used by physical therapists worldwide for upper limb rehabilitation post-stroke. However, today we will concentrate on those which have moderate to high level of evidence through research practices. So this is the outline of our talk today. The introduction, we will talk about what are the standardized consensus-based recommended assessments for upper extremity after stroke. the concepts of planning an effective therapy protocol. What do we consider? What should we keep in mind while planning a therapy protocol? There are certain recovery prediction algorithms that have been developed, which will be useful in talking to the patient and letting them know of what we are expecting, say 3 or 6 months down the line, with appropriate therapy, of course. Few secondary complications that may affect the recovery of upper extremity. And then the evidence-based interventions, of course, which will be the main focus for today. And lastly, the clinical practice guidelines, not just from India, but few other countries which talk about established protocols to be used for upper extremity rehabilitation. All right. So there are a few agreed definitions that you need to know before we get into the lecture today. First of all, rehabilitation, as defined by the British Society, is a process of active change by which a person who has become disabled acquires not just the skills, it's important to know that he or she acquires the knowledge as well towards optimum physical, psychological, and social function. So our role as a physical therapist is not just limited to the physical rehabilitation, but the components of psychological and social reintegration of the patient should also lead us and guide us in planning a therapy protocol. However, recovery is termed a little differently, defined a little differently. So we have 3 different types: behavioral or restitution recovery, which is actually the true recovery that happens. So what a patient was, how a patient presented before the stroke. If the patient is going back to that with a normal motor control, we would call that behavioral restitution or true recovery, which happens through actual neural repair. We also have something called as compensation, which the term itself is self-explanatory. So it happens through motor learning and a lot of other strategies. And of course, we have something called as spontaneous biological recovery. Even in the absence of treatment, there may be some recovery that happens. And especially in stroke, this is defined very beautifully in a graph that we'll be talking about in a few minutes. So this spontaneous recovery, like I said, is a time-sensitive window. It begins really early after stroke, and it tapers off also really early. So it is very important that medical as well as physical therapy treatment starts off during this time-sensitive window. We'll talk about what this time-sensitive window is very soon. For the arm, it is weeks to months, and for language, for autonomic nervous system, it is weeks to years. And it is very characteristic in most patients, although some patients you will see a lot of overlap. This has been studied by various neuroscientists across the world. So from one of our groups called the ISRA, Stroke Recovery and Rehabilitation Roundtable Task Force, they came up with this beautiful graph which shows the different phases of recovery after stroke. So if you see the hyperacute phase, 0 to 24 hours, that's when you're seeing cell death and a lot of negative effects of the lesion, hematoma expansion, etc. There is inflammation and scarring right from the hyperacute phase, moving on to beyond, a little bit beyond the acute phase, that is 7 to 8 days. But it is also important to notice that this phase, 1 to 7 days, the acute phase, you also see 2 important things. That is the endogenous plasticity, neuroplasticity kicking in, and the orange line that you see here, improving impairment and function. So having said this, this phase, after the hyperacute phase, is when we have to at least start the right time, the right type and right dosage of physiotherapy and rehabilitation. This, of course, extends into the early subacute, late subacute, chronic phases. And we need to know that there are many studies which talk about recovery in the chronic phase also. So the whole aspect, the whole understanding of stroke patients not recovering after 6 months and the recovery becoming redundant after 6 months is actually wrong. We do have studies which show that patients do improve even in the chronic phase. Of course, the speed of recovery, speed of response to rehabilitation is reduced, but you definitely see improvement according to this neuroscientific study. These are a few other stark differences. Because we are from India, I thought we should add this information here. If you see, this is the same graph that we saw previously, the recovery graph. And if you see, the patient recovery profile, the blue line here is that of low and middle income countries like India. So the recovery, if you see, because proper rehabilitation is not being delivered, or patients are not able to access it in a way due to different barriers, the recovery profile is much, much lesser than that of a high income country, say like UK or Australia, etc., where they have government schemes and insurance for rehabilitation, things like that. Do you see the difference here? Even in the acute and early subacute phase, which is the golden period for rehab, there's a stark difference. Similarly, one major reason, patients who access rehabilitation here, if you see in low and middle income countries, the blue line here is very, very less when compared to the high income countries. So as physiotherapists, I think it's a big responsibility on us. We need to build awareness, give the right therapy, have evidence-based practice so that we are able to make some meaningful difference. So all of us know this next slide. I will not go into the details. There are motor presentations based on synergies, based on functional differences in patients. So there is flexion, extension, and combined synergies. I will not go into the details. And I am hoping that all of us also know about the stages of motor recovery. I will limit to shoulder, arm, and hand for this talk. So stage 1 being no voluntary movement, and stage 2 to 6, it moves to more complex voluntary control over the movements. So we see limb synergies being shown in stages 2, 3, 4, and 4 or 5 and 6 onwards, patient is trying to come out of that synergy pattern, the group pattern, and moves into more voluntary individual muscular and joint movements. And that's what we see in stage 4, stage 5, stage 6, where speed is also kicking in and the patients are able to do a slightly faster movements when compared to the unaffected side. Similarly, for the hand, also more complex grasp, more complex grips start appearing in the later stages. So later the stage, near normal, more near normal is the patient. Again, these details are there in any recovery upper extremity stroke recovery textbook. Feel free to have a look at them, please. So coming to standardized assessments. Now, in many places, not just in India, but in many places, we limit our assessment to tone. We limit our assessment to range of motion. We limit our assessment to, say, reflexes or sensory function, which are all very important. But to have a quantitative outcome, we need quantitative assessments. When I say quantitative, something that is measurable, something that is understandable worldwide. So when I say a patient's status is this, another therapist 100 yards down the line or 100 cities away from me should be able to quantitatively understand without having the need to reassess the patient again. So, and there are many other, advantages of having standardized assessments. So according to the ICIDH model, which you must have heard in community medicine classes, we have different levels of this model. One would be the impairment, which is the body structure and functional issues, activity limitation, which is the functional issue as such, where the patient's ADLs are getting affected. And lastly, we have participation restriction, where we are seeing the quality of life, the patient's social and emotional status, his reintegration into the society, etc. So based on each of these levels, we have, again, the ISRA team, which came up with standardized assessments for each of these levels in the year 2017. And since then, this is what is being followed for stroke standardized assessment across the world. So limiting it to upper limb for impairment in the acute phase, early subacute phase, and all the other phases, Fugel-Mayer assessment is what has been recommended as a standardized consensus-based assessment. We will talk about it, only the upper extremity segment in this topic, in this discussion today. For activity limitation, we have something called as Action Research Arm Test, again recommended by the World Stroke Organization and ISRA. So again, in all the phases post-stroke, ARAT is a good scale to follow to assess the functions. Apart from this, there's another scale called the Wolf Motor Function Test that we very frequently use in our institution as well, where you see time-based activities and strength-based activities being assessed. For lower limb, of course, we have different scales. It's beyond the scope of this talk today, but do feel free to have a look at this paper here by Gert Quackel et al. In 2017, which will give you the details. For quality of life, as you see, you have different scales called EuroQOL, which has a 5-domain, 5-level scale. For global disability, we have modified Rankin score. And for participation, sadly, we haven't developed a consensus yet. All right. So coming to the Fugel-Mayer assessment scale, we have training and certification videos for this from our institution in collaboration with World Health Organization. So feel free to contact me if you want to get trained in it. And I'm sure, of course, many of the institutions here have already been using it. So this is a stroke-specific, more of a performance-based index to measure sensory as well as motor impairments. Now, the upper limb score, usually the shortened version, many of us use the shortened version with a total score of 66. But then when you see the extended larger version, the total score with all the domains would be 126. So it has multiple subcategories. So you have the reflex activity, the volitional movement within synergies. Here we are seeing the synergies still in effect in the patient. Now the patient in the third stage is able to come slightly out of the synergies, is able to do without compensation few different movements where there is mixing of synergies happening. So it is a little complex than the previous stage, isn't it? And then the next stage would come where the patient is able to do volitional, that is willed movements without the effect or very little effect of synergy. Again, this is a little complex than the previous stage. So we see that it is staged in a way where the tasks are getting more and more complex and more closer to normal voluntary activities of daily living. Similarly, for wrist, you have different activities to be measured and you score them on a scale of 0 to 2. You have for hand, different grasps. There's a particular way you test each of these grasps, and those training videos will show you that. I'll show you a small clip of it, hopefully now. And then we have coordination being tested, joint position being tested, pain being tested, and sensations as well. So when you combine the total score, how do we interpret it? Is that when the patient is scoring less, lower on the scale up to 35, it shows that the impairment is severe, very severe. And if the score is more, then the impairments are mild. And this is how you categorize them. We will just see a short video on this. I will just quickly fast forward it so that we don't lose time on this. We had developed this video again for the WHO training program. So I'm sure everyone knows reflexes, so I'll move ahead. Now we are looking at the second stage, second category where synergies are being looked at.
To the ipsilateral ear. Again, the same has to be repeated with the affected side which has been marked with the band. This is done so that while scoring we can assess both the side, again from the contralateral side to the ipsilateral ear. When she is doing these movements, we have to look for the shoulder retraction, elevation, abduction and external rotation. Also the elbow has to be flexed and the forearm supinated.
Now, if you saw, we saw the different list of movements that we are looking at different joints. And based on the completeness of the movement, we are scoring the patient. We will just see maybe one or two more examples. This is in section 4, where the patient is able to do volitional movements with very little effect of synergy or without the effect completely at all.
Pronation, supination, elbow 0 degree, shoulder between 30 to 90 degree.
Now, if you see in the video, the patient's shoulder is flexed, but the elbow is extended. You are seeing one part of the synergies being shown together, the flexion synergy as well as the extension synergy. Patient is not forced to, flex the elbow when the shoulder is being flexed. So he has overcome that difficulty from the previous stage and come to this. And now further, we are complicating it a little more by adding alternating supination and pronation.
Score 0 if there is no pronation Score 2 for complete pronation supination.
We'll just see one more example.
Score 0 mild movement. Score 2 complete flexion.
This is for the hand section. That was a full grasp, if the patient is able to do completely or not. We will move on to see other grasps like cylindrical, hook grasp, etc.
Mass extension. Hook grasp. Score 0 for no movement. Score 1 mild movement against resistance. Score 2 complete resistance.
So that was the hook grasp.
Thumb adduction. Make sure the patient doesn't flex the fingers. Score 0 for no movement. Score 1 movement against mild resistance. Score 2 movement against full resistance.
Now we are going to look at the pincer grasp, testing for that.
Demonstrating pincer grasp. Score 0 no movement. Score 1 movement against mild resistance. Score 2 movement against maximum resistance. Demonstrating cylindrical grasp. Score 0 no grasp. Score 1 movement against mild resistance. Score 2 movement against maximum resistance.
So on and so forth. If you have a look at the scale, you will get it free of cost online. There are many subsections. Just make sure that you are following the intricacies of the testings so that we are recording the score uniformly, no matter which physiotherapist is doing it. The last section, as in the shortened version, is the coordination and speed. We'll quickly look at it. We do it on the unaffected side first, and then moving to the more affected side.
Alternative movements are performed on the unaffected side for 5 times. Time is recorded on the stopwatch. The same is performed on the affected side. In this, we keep a track of tremors, dysmetria, and if there is slow or speed.
So that was a short video that we had developed for training. We do have certification videos as well. We can talk about it probably in the discussion session. So moving on, action research arm test. We also have a training video for this, but I will not go into the details today. This is more for the activities that we assess after stroke. It has 4 subsections: grasp, grip, pinch, and gross movement. And the total score is 57. Now, this is the kit that you will require, a standardized kit again. It can be made indigenously as well. In our center, we have made an indigenous one with the same specifications that is given in this table. So you can make it as well and use it at your centers. So again, higher the score, better is the functioning of the patient. So now coming to the interesting aspect, something that really interests me, and we have used a lot of MRI-based studies to come up with algorithms. Physiotherapists worldwide use this. So how do you predict how much of a recovery you can expect in a patient for the upper limb function? You have similar prediction patterns for lower extremities, for the trunk. For today's topic, however, we will limit to upper extremity prediction algorithm. So the first one we need to know of is the integrity, percentage-wise integrity of the corticospinal tract. Studies say that if the integrity of the corticospinal tract is mild, that is, there is severe degeneration, about 70% or more, then it is a matter of concern. But for those patients who show mild degeneration of the corticospinal tracts, the recovery can be up to 80%. It says 70 here, but newer studies have come up. Sorry, I haven't updated the slide. 70 to 80% of the upper limb function can be restored with appropriate rehabilitation. Now, if the severity of the corticospinal tract degeneration is high, then our recovery percentage reduces to below 30%. And this is how, when we speak to the patient, when we plan our SMART goals with the patient, we'll have to keep this in mind. Now, if you don't have this, how much of percentage, how much of a degeneration has happened? Every patient will not come to you with this data. Every neurologist may not give you this data or may not even have this data. Then we move on to something called as the PrEP algorithm. A newer version of it has come called the PrEP2 algorithm. Now, this algorithm is based on something called as the SAFE score. The full form of this is shoulder abduction and finger extension, SAFE. Now, this is generally performed in the acute phase, that is 1 to 7 days, usually on the 3rd day. Now, if the combined MMT of shoulder abductors and finger extensors is more than 5, so out of 10, that is 5. If they get more than 5, and if the patient's age is below 80, then there will be an excellent recovery, and you can plan therapy which can be complex and more near normal activities. Now, if the SAFE score is still more than 5, but the patient's age is more, that is above 80 years of age, do you do the SAFE score again and see that if it is more than 8, more than 5 anyway the patient had. Now, if the SAFE score is still more than 8, then the recovery may be excellent. However, if it is less than 8, that is between 5 to 8 on the 3rd day, recovery reduces from excellent to good. Similarly, if SAFE score on day 3 is not even 5, then we move on to do something called as the motor evoked potentials between day 3 to 7. So definitely in the acute phase. If the patient shows positive motor evoked potentials, then the recovery definitely will be good. You cannot say near normal. The patient will be able to do activities of daily living, at least to some extent. Now, in those where you do not see motor evoked potentials and there is additional NIHSS, poor NIHSS. Now, NIHSS is the severity of stroke index. Now, lesser the score, better is the patient in NIHSS. It's the other way around. So if there is no MEP and the NIHSS is higher, that is severe stroke, then of course the recovery will be less. And if the NIHSS is more than 7, the recovery will be limited. So this is one of the algorithms that really helped our institution physiotherapists to plan treatment and to decide and to explain to the patient what the patient can expect, say 3 or 6 months down the line. Now, the role of sensory functions also, in addition to NIHSS, is also a predictive algorithm. This was come up by the team in Netherlands. So we look at NIHSS again. If it is severe stroke or moderate stroke, that is anywhere the score of NIHSS above 6 or 7, anywhere up to the final score, then the bimanual performance will be limited or poor. But if it's a mild stroke and very mild stroke, that is between 3 to 6 and between 0 to 3, and the patient is showing some amount of grasp function, some amount of stereognosis, then the patient will have moderate or good bimanual performance. So please remember that sensory system integrity, stereognosis, touch and pain integrity is very essential in motor recovery as well. So they are connected. So these are 2 algorithms. There are many more, but these 2 are really have a really good evidence base, and that's why I'm presenting it to you. Now coming to therapy planning, what exactly do we think? So like in any textbook, you would see I've just taken it from Glenn Gillen textbook here. It is multifactorial. Upper extremity dysfunction is influenced by many factors. Pain is one, how the patient guards or the patient holds his body, the position of the trunk, etc., influences the dysfunction. The inefficiency, ineffectiveness of recruitment of the muscles, skeletal muscles, because of the lesion also affects the dysfunction, and the soft tissue variation in length because of tone or because of structural component issues also affect the dysfunction. So we need to be really careful because it is multifactorial. The cause of the dysfunction is multifactorial. So please remember, an assessment of every aspect, motor, sensory, functional, cognition, perceptual deficits is essential. Make sure that you are focusing on task-specific activities, because at the end of the day, it is tasks that the patient wants to do. Like in any approach, repetition is an important thing to think of. The dosage, setting the dosage is important. SMART goals, all of us know about this. I will not go into the details. Make sure that you're including the patient and the family caregiver for goal settings. And lastly, use standardized outcome measures to assess progress. So you've used the algorithm to predict what the recovery is. Then you set a treatment plan based on the standardized outcomes. So you do a baseline score, provide the treatment that you've planned in collaboration with the patient and the caregiver. After a few days, do the assessments again so that you see what is happening. Is your treatment even right? Is your treatment even working for the patient? So this periodic assessment is very, very essential, especially in stroke, because like I said, the first golden period of acute phase to 3 months is where the patient will show a lot of improvement, a lot of effect of endogenous plasticity and improving impairment and function. So this is a teaching slide that I have, with permission, taken from Dr. Solomon from Manipal. So we need to remember while therapy planning that upper extremity is have a lot of complex movements, higher movement complexity when compared to gait, postural stability, etc. And that is why it needs greater and greater amount of practice. There are various components in therapy that you need to think of that is listed here. When we talk about motor planning and task-based activities, you need to think of approaches like mental practice and mirror therapy. When we think of motor planning, prehension, inter-limb, inter-joint coordination, use of muscle force, think of practicing the lost elements of task-specific training. When we think of muscle force, in addition to muscle tone, isolation of each movement and not task especially, reflex function, then we talk about things like, approaches like strength, functional electrical stimulation, restraining the trunk so that compensatory movements don't happen, sensory motor training, etc. Lastly, there are traditional approaches that all of us read in our final years, Rude's approach, even Brunstorm for that matter, NDT, a lot of traditional approaches that focus on tone, that focus on isolation of movements, fine-tuning those movements, using reflexes like in Brunstorm that we talk about. So those things are there. So these are different approaches you keep in mind before planning the therapy. What would be suitable for the patient? Coming to actual interventions now, I hope I'm not taking too much time. In the acute phase, of course, positioning is a very important thing that all of us, I'm sure, are following. How the upper limb is placed, how to avoid subluxation. When the patient is lying down on the unaffected side, this is the example. When the patient is in supine, one example here. When the patient is lying down, again on the unaffected side, but then with elbow flexion, how it is supported on the upper limb so that not too much of adduction is happening. Then in sitting, how support is needed, lap trays, pillows in the acute phase when the patient's arm is flaccid. So just basic examples. There are a lot of other things, mobilization, taking care of the chest in the acute phase, but that is beyond the scope of this topic. So we'll just focus on the upper extremity. So coming to the flaccid phase, again, all of us know the support that the shoulder joint requires through either a home modified hemiplegic sling or slings like this, which allow extension at the elbow, but do not exert a pull over the shoulder joint. Now, there are slings like this as well with the elbow inflection, which is not very useful for later stages because the elbow is in flexion. Sometimes the synergy takes over. So something with extension in our experience gives a better recovery at later stages. But every patient is different. You will have to decide how the body is responding to the therapy and the sling. So there are a few pros and cons of why we need to use slings. Please remember there are negative effects also, but you have to weigh the pros and cons. Are there more number of positives for this patient? Do I have to use it, or are there more number of negatives, and can I avoid using it? So remember that. There are some protective strategies. Of course, you need to include initially the movement of trunk, which facilitates the scapulothoracic joint movements, which allows for assisted movement at the glenohumeral joint. include tabletop exercises here and including the trunk. Definitely do not use too many of the smiley ball exercises that is so freely advised in countries like ours. No overhead activities, at least in the acute phase, if you have the danger of subluxation, etc. Correct transfer techniques also should be taught, not just to the caregivers, but also the nurses in the hospital. So there are other precautions that you'll need to take. I will not go into the details. I'm sure every one of us know this. Managing edema, how mirror therapy can be used in the acute phase, why bimanual activities like we saw in these pictures here, using of a wand exercises, things like that. We will see some videos later. There are a few secondary complications that we need to remember before we plan and deliver the therapy. All of us know about subluxation and the causes for it. Now, this was very severely affected sublux shoulder and the trunk, which is leading to secondary scoliosis also. Now, the scapular alignment basically is against the spine. This is what the normal looks like. But in a sublux shoulder, you see the alignment dropping down and no inferior support for the glenohumeral head. Now, in extreme cases, it might lead to scoliosis in addition to the drop. In the flaccid phase, you see that the flaccid trapezium, serratus anterior, rotator cuff, which do not hold the integrity of the glenohumeral joint. However, in the spastic phase, we need to remember that our focus shifts to other muscle groups like pectoralis major and minor, rhomboids, elevator scapulae, which are pulling the shoulder joint into the flexor synergy. So your focus of treatment for subluxation for spastic and flaccid phase will differ because the muscles being affected are different. So, sorry, remember that as well. This is a small simple scale to remember, which talks about quantifying the subluxation from 0 to 5, 5 being the most gap between the two structures and 0, no subluxation. You can definitely use radiographic measurements, but in a clinical practice to be fast, you can use this finger breadth palpation method as well. There are various causes of shoulder pain, the secondary complication, second one we are talking about now, except for pulleys, overhead pulleys, which have shown a negative effect, which allows uncontrolled abduction. So it has a negative effect, and we do not do that for acute cases after stroke, sometimes even in subacute and chronic cases. The only evidence that we have which improves shoulder pain is with electrical stimulation, grade 1 evidence, 1B, and gentle range of motion, lateral rotation movements. It has grade 2 evidence. Now, intra-articular injections are there, but they should be used as the last option. Positioning protocol and strapping, which we'll talk about in the next slide, also have grade 1 and 2 level of evidence. It is very important that we avoid these subluxation and pain. Prevention is better than cure, because treatment of shoulder pain in stroke, treatment of subluxation in stroke has very poor evidence and very limited success rate. So these are some strapping techniques, use of K-tapes. The tri-pull method done in our institution has proven to have moderate evidence. So the upward pull has been shown here with reinforcing bands above and below. There is another Glenn Gillen longitudinal strapping method also, which has been used for many decades now. Something called as shoulder hand syndrome or the complex regional pain syndrome, and RSD, that is reflex sympathetic dystrophy. All of us know about this. It is because of autonomic nervous system changes and the positional proximal trauma to the shoulder because of the abnormal positioning of the upper limb in synergies in stroke. So it has 3 different stages. Depending on which stage the patient comes to you, your treatment will vary. There is something called as central post-stroke pain, which we need to be really careful about. It is very different from the localized shoulder pain or shoulder hand syndrome. Now, this pain is due to the involvement of the somatosensory pathways at any level. It can be the thalamus, it can be the somatosensory tract, it can be at the receptor level in stroke. Now, this is very severe, persistent, long-standing. They feel as if there is a burning and aching sensation or shooting pain. It can be intermittent at times, but then it's very debilitating. And the interesting part is it can present as a focal or a generalized post-stroke pain. So it's very essential. The whole half of the body affected side also can show pain in thalamic lesions. So there is very little evidence for pain of this sort. Like I said, anti-gravity, anti-spastic patterns of placement, etc., have not proven to be effective. So let's not waste our time on that. Strapping, like I told you, for central post-stroke pain has grade 4 evidence, which is very, very poor. Slings have only grade 2. Gentle mobilization, joint mobilization techniques, and corticosteroid injections are the two ones mainstay which have good evidence. So other than that, if it's a central post-stroke pain, it is questionable of how we'll treat. So prevention is better than cure. So these are some approaches we can use if it is psychological, central, autonomic pain, or peripheral pain. Make sure that you're looking at the multiple factors that are kicking in. Coming to the intervention strategies, we saw of what to consider, the complications and the therapy planning. Now we are looking at the actual evidence-based approaches. I will be talking about 4 things today. In short, one is mirror therapy. All of us know about it. It has moderate evidence, that is level 2. But for pain and visuospatial neglect, the evidence is low. For sensory and motor improvement, the evidence is moderate. Now, it is interesting to know that in thalamic and parietal lobe strokes, even for central post-stroke pain, there is recent evidence that mirror therapy improves the motor activities in such patients. Now, this is at our center. This is a mock patient. It's not a real patient. And we will see a short video now describing mirror therapy. Again, this was developed for the World Health Organization.
Mirror therapy is an evidence-based rehabilitation approach proven to be effective in treating various impairments after a stroke. It is one among few physical rehabilitative approaches allowing for true recovery through neural reorganization through the motor neuron system. Place the affected arm behind the mirror in a way that the patient cannot see it. Repetitive anatomical movements of the unaffected arm are to be performed. The patient is instructed to observe the reflection of the movements performed, which gives the illusion of movement in the affected limb. Exercises involving bimanual activities should be incorporated for improved motor outcomes. Functional activities should be incorporated in every treatment sessions for effective carryover of treatment effects into activities of daily living.
All right, so I'll stop the video here. If you saw, we need to include both anatomical movements as well as activities, task-based activities in this session. The advantage of mirror therapy is that, like you heard in the video, it is the unaffected side or the less affected side that is being put to use, and the patient is asked to look at the reflection of the mirror. So even in a completely flaccid upper limb case, this evidence-based intervention can be implemented in the patient. So how does this work? It is kind of based on the corticospinal pathway via the mirror neuron system. Now, this is found in the frontotemporal region and the superior temporal gyrus, very similar to action observation approach. Now, it increases the self-awareness as well as spatial attention by activating the regions that I just mentioned. Now, it is important to also know that the posterior cingulate gyrus is also getting activated here because it sustains that activation and allows it to stay for a longer duration of time. So let's not go into medical jargon here. It is just helping us promote normalization of balance between the hemispheres, the affected side and the unaffected side. So basically, it is modulating the excitability of the primary motor cortex from where you get the signals for the motor processes to happen. Now, it is important that we are not looking at the the FMA score of the affected side. We are using visual feedback. We are using somatosensory input on the unaffected side so that we use those to rehabilitate the completely flaccid limb also. So acute phase, definitely think of starting mirror therapy. Now, the dosage we have found through our meta-analysis, this is one of our papers from our center, that a duration of 20 to 90 minutes, 3 to 5 weeks per session for up to 8 weeks with a mean of 4 weeks is usually useful. Now, for upper extremity specifically, 20 to 60 minutes a day is also good enough. The advantage being such things can be done at the home of the patient as well. Coming to CIMT, again, all of you must have heard of this. We will just look at another video.
Constraint-induced movement therapy, or CIMT, is an approach to stroke rehabilitation that involves the forced use of the affected arm by restraining the less affected arm.
So in mirror therapy, we saw that the unaffected arm is being used. In CIMT, it is the affected arm being used, forced use, so that the learned non-use of the affected side is overcome. Of course, this also involves functional activities.
To select the ideal patient for CIMT, the patient should be able to perform certain movements. 10 degrees active wrist extension on the affected hand, 10 degrees active thumb abduction on the affected hand, 10 degrees active extension of any other 2 digits on the affected hand.
So this is called the 10-10-10 criteria that the patient needs to already have so that you can implement CIMT. So this is one, I wouldn't say disadvantage, but one difference between mirror therapy and CIMT. Mirror therapy can be used in any patient, even if it's flaccid, but in CIMT, patient needs to have at least those 10 degrees movements, or the 3 different 10-degree movements. Additionally, if they have these listed out points here that you see on the screen now, it is better.
Choose the tasks ideal for your patient. Use either the shaping method or task practice method. Package of behavioral techniques or transferring therapy gains to activities of daily living should be implemented following intervention. The shaping method involves gradual increase in the difficulty of the tasks performed either by increasing the load or size or the effect of gravity.
So we're just showing you some examples of how to make the task more and more difficult. These are not to be followed in the same way as it is showed. Every patient is different, so you need to individualize, customize it. These are only examples.
Only one shaping parameter is changed at a time. This method requires constant therapist supervision. A set of 10 to 15 tasks are predetermined according to the patient's need. Each task is usually performed in a set of 10 to 30-second trials. At the end of each set of 10 trials, the task is changed. Task practice method allows for repetitive practice of individual functional tasks that takes approximately 15 to 20 minutes. Rest is provided as required and feedback at the end of every task. Patient should be encouraged to implement the learned motor activities into his or her daily life. They can be encouraged to keep a log of their physical activities done throughout the day. The therapist can provide a checklist of activities that the patient needs to focus on through the day, which can be evaluated and modified in following sessions with the patient.
All right, so that was just a guide for all of us to remember before we use CIMT. Now, this has level 1 evidence, although the grading is C, but level 1 evidence for both traditional as well as modified CIMT protocols. Please remember that it is functional tasks that we focus on here, and we are using the affected limb to do the various activities. Different types of restraints, you can use the same hemiplegic sling to restrain or something like a mitt. Now, traditional approach talks about restraint for 90% of the waking hours, which definitely will be annoying to the patient. Most of us do not use this. However, there are modified protocols, something that follows the distributed task practice schedule. We'll talk about this later. Now, here we see task specific practice 30 minutes with only 5 hours of constraint, 5 days a week for 10 weeks, or it can be less than 6 hours of constraint, but really intense 30 minutes to 3 hours of therapy for a shorter time of 10 weeks. Or it can be 10 weeks again, 3 sessions per day and intense 30 minutes per session. Now here for this last type is what we follow at our institution. But here the FMA score needs to be good, moderate to good. Coming to, we spoke about shaping principle in the video itself, task practice method and the functional method. So I will not go into the details, some reading material for you. Coming to robotics, it's a big topic in itself. We cannot go into the details, but this has very high evidence, especially because the number of repetitions that you can do is high in this, which is very essential in physical therapy rehabilitation. So robotic exoskeletons and end effector are the two major types that you can talk about. You also have different types, really costly or sensor based, I would say. But for today's topic, I will focus on something that our counterparts in CMC Vellore have developed in the bioengineering department. Very low cost, lightweight, which can be used at homes of the patient as well. So I will show you some pictures and videos of that. We use it on our patients here. Now, this is a table which is simplified. Now it is a much smaller functioning unit. You will look at the grasp function, cylindrical grasp function here, which can be changed and modified to different types. Now this you see for finger opening and closing. Now this you see for supination, pronation and things like that. Now this was for the shoulder and elbow. You have non-robotic systems also. This is computer game-based therapy where the patient is interacting with the screen here. Again, low-cost device. If you see, there is no robotic system attached to him or him using it. It is game-based. And you also have wearable watches, which allows you to track the movement of the patients. Very interesting technologies that are becoming cost-effective now. And let's have a look at some videos. Now, this is for supination, pronation. This was just on the 3rd day. of therapy. He is a case of chronic stroke. He had come to us 1.5 years after the stroke from a rural community. He did not have access to rehabilitation, Mr. Hardeep. If you see, there is severe flexion synergy. I will show you, maybe you see the video first and then I can explain. So this is a computer game that the patient is interacting with while using the robotic system down here. He is supinating and pronating, and that is interacting with the screen. So now if you see, when he is trying to supinate, he is bending forward. So supination, he is trying to flex the elbow. He is using synergy to cause more supination, which is not good. But like I said, this was just the third session, so we were allowing it. Slowly, we will put a restraint here as well, so that he is not bending forward, not using elbow flexion, but purely doing supination and pronation. So this is just one example. Let's look at the other patient. Hand opening and closing. That is lumbrical grasp, a little bit of pad and dab also working to some extent, and abductor pollicis is also working to some extent. So if you see here, he has to open and close while interacting with the screen. It's the same game, but a different model for a different hand activity. All right. Probably one more example maybe of a pincer grasp. Let me show you that. So if you see, it is like a key that the patient has to use and rotate it on either side. So you see, so not much of supination pronation, but probably radial ulnar deviation with pincer grasp. You do have some supination pronation, but we have restricted the movement here so that it is the fine motor aspect that is functioning. Now, this patient came to us quite early, so you don't see him using a lot of trick movements. We were able to treat him successfully. So these are a few examples of the robotic system that we used. What else? Yeah, let's go back to the PowerPoint. Now, the other thing that we use in our center, like I said, is computer game-based rehabilitation. Very, very simple. If you see this blue structure here, that is a wireless mouse, very, very small in size, say 2 by 2 inches, which is mounted on structures like this, the instruments like this, soccer ball, activities of daily living, the items that you use, a vestibular ball. And now that movement of the mouse, when the patient moves the ball or any other object that you have placed the mouse on, makes it interact with the screen, and again a game is played. It is again cost effective because you don't have to buy a Sony PlayStation, you don't have to buy a Nintendo Wii or things like that. You just need the mouse and a simple laptop. There are so many free games online. Choose the right one in the vertical plane, in the horizontal plane, whichever plane you want the activities to happen in. Choose the game and then ask the patient to do the movements. Repetitions increase, interest increases, motivation increases, and functional grasp grip also you can deliver through this. So this is a paper that we had published. You can have a look at it. The details are given here, the European Stroke Journal. So different grasps, conical, pincer, spherical, pad to pad, can be used in treating the patient. Lastly, we have task-oriented training. The name suggests it all. It has level 1A evidence. All the approaches that we previously talked about includes tasks in them. So this has this is like the pivotal point of physiotherapy for stroke rehabilitation, and of course for other neurological conditions. Task-based training. We need to move from our redundant thought process of treating tone, of reducing tone or reducing the impairments because of stroke, and focus on the tasks, irrespective of what the impairment is, even with spasticity, even with issues of hemi-neglect. How can I make the patient able to live his life on his own should be the focus. Of course, treating the cause, treating the impairment is important, but making the functional recovery of the patient should be held at a higher level. So there are a few practice structures that we use here in task-based. It can be constant versus variable. The tasks that you use can be blocked, random, or serial. So if you are choosing, say, 3 tasks, this is the example given here. So task A, you perform all of the tasks set A, then do the set B tasks, and then do the set C tasks. If it is serial, you make it a alternate. Do A, B, and then C, go back to A, B, and C. So you're making it variable for the patient. Random, you just pick and choose at random so that the complexity and demand for the patient is more. You have massed versus distributed practice. In massed practice, the amount of practice time is more, rest is less, and the other way for distributed practice. Now we saw that CIMT is a form of distributed, can be applied in the form of distributed practice. In traditional CIMT, however, it is massed practice, isn't it? Because longer duration of restraint and activities. Feedback is something very important in task-based approaches. And again, it is a big topic on its own of when to give feedback, how to give feedback, what are the timings, and how frequently can you give, etc. Just like CIMT, the same criteria is needed for task-based. At least some movement needs to be there for you to ask the patient to do tasks, right? So this criteria is not applicable in mirror therapy because even in flaccid cases, you can use it. Now, make sure that the tasks that you choose should be relevant, should be done repetitively. Patient should be able to reconstruct it and apply it to his daily activities. It can be randomly ordered, like I said, to make it more challenging for the patient. And of course, it should be reinforced by transferring it to behavioral activities and positive feedback that we give to the patient. I will just show you we are coming to almost coming to an end of a lecture, but I will just want to show you a few task-based activities that we use at our center. This is again one of our patients. Of course, we don't do this on a daily basis, holding coins and pulling them together, but you see how much of an excursion the patient needs to apply to do simple activities like this. And he's stabilizing it by himself. So all these can be done at home. Fine motor activities. Things like, this is one example for stabilizing the shoulder joint while moving the distal aspect. So we are adding a weight here so that a long lever function is achieved and the patient is able to roll it. If you make it short lever, make this band shorter, it makes it more difficult for the patient. So modify, use your creativity, modify exercises, use what you see around the patient's house or what you have in your institution. Change and make a lot of customizable exercises. Don't stick to what is given in the textbook. Don't stick to what you have learned in NDT or RUDS. Don't stick just to that. Make it more comprehensive and customized. Now this is simple rolling of the ball where we are challenging the patient to use his TIP and PIP flexors by doing these movements. There are other exercises. If you remember, we spoke about the wand exercises, bimanual tasks in the acute phase, where a little bit of spasticity has come in, little bit of voluntary control is there, and you are asking the patient to do bimanual across the midline activity. So it has to cross the midline. So this is the same patient that we saw in the robotics video. This was his 3rd day, the same day we were recording it. He has improved now. If you see, whenever he is doing abduction of the affected side, he is flexing his elbow. So he's using his synergy. And slowly, I hope that he will get out of it. And we are adding exercises for improvement in this patient. Yeah, there are many more videos, but I think we will stop here. You can feel free to ask me if we have the time to interact later. So when we talk about recommendations, functional task-based activities has level 1A evidence. All of the patients should need individual customized training, and activities of daily living, instrumental activities of daily living should be taught at discharge. All these three have level 1A or B evidence. Now, robotic therapy, this is an old, if you see 2016 guidelines, there are new guidelines that have come which talk about robotic therapy, NMES, which have level 1C evidence. Please remember that somatosensory retraining, which is not in the scope of today's lecture, is also very important for motor outcomes. Bilateral arm trainings, we just spoke about it. And one thing to remember, something that is not recommended by these stroke rehab guidelines is acupuncture. It may be controversial. Many people use it. Many patients have seen improvements. But from the physiotherapy side, this is something that does not have much evidence, at least according to this guideline. Functional electrical stimulation for shoulder subluxation and the other impaired muscles can also have to be seen as one level 1B evidence. Please remember that anti-spastic positioning, plain passive range of motion exercises, stretching, splinting, serial casting, poor, right? This is a keyword, very, very poor evidence. Let's not waste time over that. Activities, task-based activities, evidence-based approach is what we should focus on. I will quickly go through the clinical practice guidelines. This is our last slide. When I say clinical practice guidelines, these are all based on various systematic reviews, meta-analysis by experts around the world, which together they have brought to make some sort of guidelines for us to follow. Fortunately, India also has one released in 2019. However, similar to other countries that are listed out here, when we compare it to the Australian guidelines, which is a very standard guideline, there are many, many differences. So when you pick and choose protocols and guidelines to follow, make sure that you're choosing the right one. Let me just give you an example. You can find this. This is one of our papers again, published in Lancet. So this is the reference. You can go ahead and see. Take for example, hand-wrist orthosis. The standardized guidelines say that you should not use it unless there is nothing else working. But see the Indian guidelines, we still say that you can use it. I'm not saying you should not. What I'm saying is try everything and under the sun before you decide to just give a passive splint and let the patient sit at home. So this is one major difference. Similarly, if you see about early mobilization, within 24 hours, the standardized guidelines say no. But in the acute phase, after 24 hours, you definitely have to do. What does Indian guidelines say? Early mobilization, not applicable. They have no idea what's supposed to do. But then at least this, they have incorporated it. So make sure that you are following the correct guidelines. See what is suitable. Read articles on your own. Read research articles on your own and come to a conclusion. Now, there are many more comparative studies that have recently come up on evidence-based approaches. Make sure that you are aware of them and don't limit your creativity skills. I always say to my students that neurophysiotherapy is something that makes you very creative. I'm sure the other fields of physiotherapy also are creative in their own ways, but our interaction with the patient is over a long period of time, acute, subacute, chronic, moving on to years. So you need to be very creative. So in summary, be sure to use the correct assessment tool, the correct intervention strategy that is informed by assessment, evidence, and the stage of stroke. Choose the correct clinical practice guideline. With experience, you will learn this. Tailor-make individualized plans. Don't just use the same thing for every patient. Progression of intervention should be assessed periodically by using outcome measures that we spoke of, FMA, ARAT, Wolf Motor Function Test. And lastly, it should be a holistic approach. And by holistic, I mean two things, not just motor, sensory, cognitive, perceptual, complications, everything has to be considered. That's the first one. Second one is, don't just think, you must have heard in Dr. Pandian's lecture recently, who is also from our institution, why a multidisciplinary team is very important in neurological physiotherapy, especially in stroke. It is not just the physiotherapist. Everything is not on our head. It is the occupational therapist, it is the social worker, it is the physician, it is the neurologist. Everyone need to work together so that the patient's life at the end of the day, quality improves. So I hope this made some sense. I'm sorry if I took a long time. Feel free to call me with queries or suggestions at this email ID. Thank you once again for this opportunity. Sorry, ma'am, if I took a lot of time. You're on mute, ma'am.
Hello. It was so interesting that we could hardly feel that, yes, it has extended time. Thank you so much for that extensive and a very clear update with keeping in mind all the previous traditional systems also, and coming up to what is up to date with proper evidence base. I don't find that you have not touched any aspect of it, and you have summarized it so well that the viewers, those who will be viewing it, would really feel that they should not have missed it. So that's so nice of you. To add on, like how you summarized, yes, you need to have a team effort. You need to have a better tuning with all the team members. You should always have a dialogue with the team members. It is not one-to-one approach. It is always a team approach where we come to a common consensus and then we treat so that it is for the betterment of the patient, wherein we also take up the family members or the caregivers as a team. They should not be left out. And whenever the patient is in that cognitive phase where the patient understands, even his opinion is to be taken care of. What he wants to achieve has to be taken care of. So going ahead with it, yes, it has to be task oriented. It has to be tailor made. You need to know what you want to achieve. You need to know what the patient needs to go, where the patient needs to go. Yes, and whatever you treat, whichever intervention strategy for whether improving the impairment or the function, it has to come to a level where the patient is able to do his function, where the patient is able to utilize that treatment, and he has to come to his near normal. He may use any type of therapy. That is not the question. But then, yes, finally, what we need is it has to be a holistic approach, and the patient should benefit on the functional level, on the behavioral level, where he comes back to his near normal. It still depends on how severe it is, but yes, we have to find out what best we can do, and we may try anything on the world. There is no limit to it. Yes, as you said, very rightly said, the creativity is a must. You have to find out your own ways. It never has to be anything that this school of thought has said or somebody else has said or we have learned this. You can always evolve. If you keep your mind open, yes, you can always evolve. And even I feel that even I have evolved today by joining you all. Thank you so much. It was so nice. Thank you.
Thank you, ma'am. Thank you so much.
Thank you. I would like to thank both the speakers, Dr. Khatri ma'am and Dr. Gandhi ma'am,